So thanks for the opportunity to talk. I think compared to some of my esteemed colleagues, I'm a bit of a Luddite in the world of kidney medicine, so I feel a little bit out of place here. But I certainly do see a lot of people with chronic kidney disease. I've got a large practice of people that we see, and I guess this gave me an opportunity to have a think about what we do and why we do it, and how it's how it gives people an opportunity to help themselves at times, and also how we can encourage people to go down certain pathways to improve their health and well-being in the long term. So the overview, we'll talk about a couple of bits and pieces, a couple of bugbears of mine at the start about what's real and what's not when it comes to information about CKD and kidney failure and so forth, some lifestyle factors, and then some specific conditions where we've got some treatments, some newer treatments where we're making some changes and moving away from some of the old practices, and also finally just touching on a couple of trials. But Richard's talked a lot about trials already, so that'll be pretty brief. I've had great fun with Donald Trump being president in the US. I think the term fake news has pervaded our culture in such a way we'll never forget it now. It's the same though with anything in life. If you get online, you can read almost anything, and if you have an opinion about something, you're likely to find someone who agrees with your opinion and will provide advice that seems to fit with your thoughts at that moment in time. And you do need to be very careful about what you read online and how you take that information, how it impacts the rest of your medical care. And this was my favourite website. My apologies if anyone does like crystals, but I'd like to also think, I was going to say that this was me who wrote into them and said I just used S as my name, but it wasn't me, unfortunately. But I've had a number of patients who have gone online, and some who have spent a lot of money on treatments that, the people who were providing them didn't even suggest that there was any evidence for what they were offering, but were happy to take people's money anyway. I think everyone's got different beliefs about what sort of treatments work and who they trust and what they're willing to spend money on, but I would just suggest having a critical analysis in your mind about what you're actually doing. So these crystals, for example, they're beautiful and they're incredibly expensive, but I'm not sure how useful they are. But even you see it with elite athletes, that there was an idea about wearing a bracelet with a magnet in it, and it was being taken up by a whole lot of AFL footballers. And granted, most of them came from Victoria. I can understand that there may have been some issues with intelligence, but these things had no medical basis. Even in mainstream media, though, you can get tricked into purchasing things that you think are actually healthy for you when they're not. And I think some of you might be on dialysis in the audience, or have been told about salt in your diet. And if you go into a supermarket, you might see Master Foods tomato sauce, reduced salt, and you look at it and go, think, fantastic. I come from an Indian background. There's salt-sensitive hypertension in the family, so I'm always looking for a low-salt version of something. And I pick this up and think, this is excellent. This must have almost no salt. But in fact, it's not almost no salt. It's in fact just a little bit less than a whole lot of salt. And really, you need to be making informed decisions about what you're putting in your mouth and what you're eating. And to add insult to injury, I thought, it says here, great with pies, burgers, hot dogs and hot chips. So clearly this wasn't targeted at people who were needing a low-salt diet. So there's some confusing advertising that's going on. And I think when companies are self-regulating this, you need to be very, very careful. But there are tools that can help you negotiate this. And I'm not sure how many of you have seen the Food Switch app. It's an app that's on Apple and I think on Android as well, which essentially will scan barcodes. So anything, we know that salt, for example, is high, there's a high content of salt in foods that are in packets or jars. So anything that's processed will have a high salt content. And so the Food Switch app, which was developed by the George Institute and supported by Bupa, which I have no shares in, they have collected data about 20,000 or more different foodstuffs. So essentially you can go scan your packet of chips that you've got a real craving for, and it might say, look, this has got 1.5 grams of salt in there, which is more than your recommended, of sodium, which is more than your recommended daily intake. But the good thing that it will do is it will give you an alternative or multiple alternatives which have better salt content. So you can go away and try and chase up those brands if you still want to be eating those sorts of foods, or as a minimum, at least you're thinking about what it is that you're eating and when and how you might have it. I mean, the advice that I give to my patients, like I'm clearly not someone who avoids food. You need to try and be good when you can be, but when you're in a situation where you really want to do something, go ahead and do it, because you're not going through this process of kidney failure management or dialysis or transplantation just so that you can follow the rules. You're doing it to enjoy your life and to live your life, and you've got to find the things that you find enjoyable. And, you know, within reason, follow those and keep having them in your life. So I'll talk about a couple of specific conditions where we've got some treatments. Polycystic kidney disease is one of the more common causes of kidney failure in Australia. So about 1 in 1,000 Australians will have polycystic kidney disease, and around half of those will end up with end-stage kidney failure by about the age of 60. And we know that it's due to abnormalities in certain proteins within the tubules of the kidney. And don't worry about this picture too much, but essentially the tubules that come from the filtering units in the kidney have little hair-like projections on them, and they know which way fluid's moving, and they've got all sorts of different roles within the kidney. They also can help with movement of fluid and salt and so forth. And with polycystic kidney disease, we have an abnormality in the proteins on the side of this little cilia, and it can end up that these tubular cells become abnormal and can block, and they form cysts, and then those cysts can start to produce lots of fluid. The only treatments that we thought worked in the past was about blood pressure control and using specific blood pressure agents for that and trying to live a healthy lifestyle around it. But what we now know is that if you can increase your urine output essentially by drinking more, you can decrease the amount of secretion of fluid into these cysts. And the way that this causes kidney failure is that the cysts grow and then squeeze the normal kidney tissue around them. So they essentially deprive that tissue of blood supply, and that tissue slowly dies away. So one of the easiest solutions is to drink more, and there are trials running out of Westmead Hospital where they're using a dietitian intervention to alter diet, low salt, which is a key to everything, but to drink more fluid. But we've also got new pharmacologic agents which are called Vaptans, which act on one of the water channels in the side of these cilia. So tolvaptan has been approved in Australia very recently. It will make you pass more urine, you'll become more thirsty, as a consequence you'll drink more water, but it has an impact directly on some of the receptors in these cells to try and reduce cyst growth. And in fact they're seeing a 30% reduction in the rate, a 30% less decline in kidney function over the first couple of years from when you start this medication. So there's some real possibility and hope with that drug that we can prevent end-stage kidney failure. We can delay it at least into the longer term, and hopefully with other treatments coming online in the future, perhaps we'll get even better outcomes. So diabetes and kidney disease, I think everyone in the room would be well aware of the impact of diabetes in Australia. And there's thousands of new cases, tens of hundreds of thousands of new cases being identified all the time. It's due to lifestyle factors, diet, all sorts of things. But we see a massive impact of diabetes as a cause of kidney disease in Australia, and also as the number one cause of end-stage kidney failure in Australia now compared to what it used to be like 20 or 30 years ago. So we're really interested in treatments that can help with your diabetes, but they can also then maybe help with the kidneys beyond just reducing the sugar burden and the inflammation and oxidative stress that goes along with that. So I've got a really complicated slide here, which I don't want anyone to read, but just to know that it's really complicated. I remember looking at watching TV one night, and there was an ad. It was an aspirational ad from a car company saying, look, every other car company is trying to run their cars on less fuel, so there's less emissions. Wouldn't it be better if we had a car which used a fuel which produced oxygen and water instead? And it was an ad for a hydrogen car, I think. And this drug that I'm about to mention is kind of like that as well, where you're doing one thing and then you've got another additional benefit that comes out of it, which is completely separate, well, attached, but a little bit different to what you're initially using the drug for. So with diabetic medications, they all have different sorts of mechanisms of action. So we've got classic insulin, where you're replacing insulin. You can have situations where you're trying to increase the sensitivity of the body to the actions of insulin, or trying to increase your own insulin production. This new class of drugs essentially forces your body to excrete sugar or glucose in your urine. So you're reducing your blood sugar levels by getting rid of the sugar in the urine that you pass. But along with that, you're also your body is forced to excrete sodium or salt, and water goes with that as well. And some of the side effects of this drug have been to lower blood pressure. It also lowers the kidney filter pressure. So all those, that couple of million little filters that we've got in each of our kidneys are suddenly feeling less pressured by blood pumping in hard into them and causing damage. And the overall effect of that is lower cardiovascular risk and also benefits to the kidney over the longer term as well. So this is a real paradigm shift in how we're managing these comorbid conditions, where you're treating one condition thinking, look, it'll have a secondary benefit for the kidney, whereas in fact you're actually getting a primary benefit for the kidney. And we hope that in the longer term we'll get more and more medications that start to act in these very novel ways. We shouldn't forget the simple things that work anyway. There's a lot of data out there about early referral and education, and I think that the conversation that was being had before about informed decision making is the most important one. I know that if I have a patient who I have seen for a long time, who trusts me and who I trust, we will be able to make an informed decision together about what their treatment pathway is going to be in the longer term. They're generally more motivated to make decisions as well, and they'll do it in a timely fashion. And the outcome of that is that people live longer and they're in hospital less when it really comes to the crunch, because they've already got a plan in place for what they need to do. And there's lots of studies looking at this and meta-analyses that have been done by an Australian group in the past as well. So it's not when you don't go to the doctor and just talk about, how your dogs are going or where your next trip is, but you're actually making plans about things. And then if things do turn for the worse, you know what to do, and you're informed and you're ready, and you're not scared or worried by that process. And that's probably the most important thing. You need people that you can trust with your treatment. It doesn't matter, what the evidence is. If you don't believe the person in front of you, it means nothing. So clinical trials, I won't go into this for too long, as Richard was far more equipped to talk about that than I am. But we know that there are different phases of trials, as he spoke about. And there are many that are running in kidney disease, and many more than there used to be, which is great. A couple that I wanted to just touch on was gout, for example. We know that gout is caused by elevated uric acid levels. We know that elevated uric acid levels are associated with worsening kidney function, but we don't really know whether lowering those uric acid levels makes a difference to our long-term kidney outcomes. So there's a study looking at allopurinol use for that. Iga Nephropathy is a very common cause of kidney disease in Australia, and it's an inflammatory condition where you have antibodies against parts of the kidney and parts of the filter, and its presentation can be either with nothing, or you can have some blood in the urine, or progressive kidney disease in a percentage of those patients. We had always thought that because it was an inflammatory condition that we could use steroids to suppress the inflammation, but we're not really sure about what dose of steroids or whether we should use steroids at all. So there's the testing study with slightly lower dose steroids now than before, looking at whether or not we can make an impact upon the natural history of this condition. Recently in The Lancet, one of the big international journals, a couple of groups have revisited a treatment that I think we'd probably given up on a few years ago, which is renal denervation and management of high blood pressure. So the kidneys are, intrinsic to blood pressure control, and we know that high blood pressure is a significant risk factor for progressive kidney disease. So anything that we can do to improve blood pressure control will be better for your kidneys in the longer term. And some of the novel things that have been looked at over the years have been, if you've got a narrowing of the blood vessel, can we open that up and improve the blood supply? Does that make a difference in the longer term? And the answer was yes in only certain situations, but not all. And then there was renal denervation, which was based around the fact that your head's connected to your body. Your brain has control over various aspects of your health, whether you're conscious or subconsciously or consciously aware of it. And one of those is that if you're stressed, for example, you know that your blood pressure can go up, and there's part of that is through a nerve supply or nervous system output that goes to the kidneys, and those nerves run around the renal artery, the main artery that feeds into each of the kidneys. So the idea was that you might be able to burn those nerve fibres from within the blood vessel and cut them off, and so then not have that message going to the kidneys that, to increase the blood pressure through whatever mechanism the kidney was going to use. So there was a lot of concern about whether this was a good thing to do previously, whether the techniques were effective, whether they were long-lasting, what the complication rate was. No one really knew what the long-term sequelae from this sort of treatment was going to be. But there's been some new studies that are bringing some new insights into it, and this was one of them, looking at a new device which has a slightly different way of burning the inside of the blood vessel and doing it in a way which hopefully doesn't lead to narrowing of the blood vessel. It's a relatively straightforward technique, a bit like an angiogram. Well, it is an angiogram, and then with a wire that's inserted, and they burn each blood vessel in certain points. And they did it. It brings up interesting thoughts about research. That they gave everyone an angiogram, but only half the people, and there's only sort of 40 people in each arm at this stage. Only half the people had the procedure done, so the other half had a sham operation. But that was ethically cleared because I think it's an important question to be asked. I mean, there's a placebo effect. If you know that you haven't had a procedure, it may impact how you react afterwards. But you can see here, it's very hard to see, but you can see that from before and after the procedure, this is on a 24-hour blood pressure monitor, that there was a significant reduction in the overall blood pressure for the people that were treated, but not in those who didn't have any procedure performed. And it was equivalent to starting a new blood pressure medication. And this was in people who were already on 2 or 3 medications. So I think that in itself is quite interesting. What I actually found even more interesting goes back to what I was talking about trust and accepting between the patient and the physician about what sort of treatment's going to be given, that even though these were patients who were in a clinical trial and knew that they were going to be followed very closely, not everyone was taking their medication on a regular basis. And I think it's really important that for people who are being prescribed medications, that if you're not happy with it, or you're getting side effects, or the timing of the medication is wrong for you, tell your physician and let them know. Otherwise, we'll have a tendency to want to do something and keep giving you more and more stuff, which is just going to cost you money and not do anything. And I think it's important to have open communication with your physician about what it is that you're willing to do. Because just because we think that a treatment's good for you doesn't mean that you necessarily feel the same way. So the last thing that I'll talk about is the kidneys and the gut. You may have heard about faecal transplants and those sorts of things which have been in the media over the last few years. There is an association between kidney disease and gut function, and also gut function and kidney disease as well. I mean, we have kilograms of bacteria in our body, and it stands to reason that they're going to exert some influence over how our body functions. We know that certain breakdown products from food can affect the type of bacteria that are in our guts, and they can increase the types of waste products that are present within our gut. So for people who are on dialysis, that can have an impact upon the types of uremic toxins that we see, which can make them feel better or worse. We know that with kidney failure, your gut function, your gut motility can be altered over time as well. We know that your appetite can change. We know that we're restricting the sort of foods that we're suggesting to restrict your foods in certain ways, which may actually negatively impact upon your gut flora, and it's a bit of a vicious cycle. So it's been very pleasing to see that there's more research going on into the gut microbiome and about how we might be able to positively impact people's health and well-being through altering that. So I'll finish up there. I think going back to politics, we've been blindsided over the last few years with all these changes in leadership and the evil machinations of our politicians in Canberra, when really we should be thinking about the important things and trying to continue to focus on our health and well-being and research and those sorts of things. Thank you.
Have we got any questions in the room? No? Stephen, got any in the... We're just checking if there's any online ones.
Yes, from Amber, thank you, in Queensland. I feel like I'm on one of those radio shows. How do we change GP perspective that CKD care is not just specialist responsibility? How do we get our GPs and specialists to work together to deliver integrated care? There's an easy one.
I think none of the questions are easy, are they? Look, I mean, there's lots of initiatives by nephrologists and other groups in Australia. I mean, Kidney Health Australia has been key to that. They provide education materials to GPs, education sessions, which a lot of us have provided over the years, and the KHA, acts as the advocate for the patient, for the patients in Australia and for the nephrologists. I think we, even at a more basic level, the way that we've changed reporting of kidney function on blood tests from a number of years ago has highlighted the, how common CKD is to GPs and to refer onwards a bit earlier. But I think it's really the job of the physicians, I guess, once you have a patient that you're sharing care of, that you involve the GP as much as possible. And I think at times there are fears from GPs about not getting involved because they feel that patients can be too complicated or they're worried that they'll make a mistake. But I think everyone needs to be empowered, and clear communication lines are probably the main thing, and education, obviously.
There's a follow-up question. Who is best placed to have the behaviour management conversation, especially for early chronic kidney disease, and what can be done or what can we do as an industry to improve this?
So who should have the conversation? Well, I think everyone should have the conversation. So, I mean, I can only use the example of our hospital. We've got a chronic kidney disease service, which I'm the number one referrer to, I think, even though I don't have the most patients. But our CKD service involves not me. It involves a social worker, it involves a clinical psychologist, it involves a nurse practitioner, a CNC and a dietitian. And the GP provides advice, I provide advice, but then there's this group of people who sit down and talk about all aspects, the psychosocial aspects of chronic kidney disease. And I largely refer people there for motivation reasons, I think, to understand why we're suggesting the things that we are and how we might be able to assist people in achieving those goals. But we need to use everyone in the allied health group, I guess, to help, because the physician may not have time or may not be the right person. Others may be able to build rapport in a better way. And sometimes I know that I may not be the best doctor for that patient, and I'll refer them on to a colleague of mine who I think might get more cut through with their conversation.
All right, any questions from people in the room? All right, we'll let you off the hook.
Thank you so much.
Thank you.
Thank you very, very much.